This podcast is for educational purposes only. Please consult your doctor before changing any medical care. This information, products, or comments contained within this podcast is not approved by the FDA for the treatment or diagnosis of any disease. Although we attempt to keep the information up to date and current, we cannot guarantee the information is up to date at the time of this recording. Individual results will vary. No one should expect the outcomes or results mentioned or described in this podcast. Health shares do not constitute health insurance and do not provide a guarantee to pay for your medical bills. Please consult your broker, general counsel, and/or doctor before changing your healthcare plan. Envita and Envita Health makes no guarantees for outcomes and results. Thank you for joining us. Today we're doing a review of a triple negative breast cancer case review, and I think these are good to do. I know we're really busy. I'm Dr. Dino Prato, founder of Envita Medical Centers, CEO, and Dr. John Oertle, Chief Medical Director, and involved in a lot of the plan design. So we're just going to jump right in. So John, I'm glad that we get some time out of our busy schedule to go over this, but this is a triple negative, difficult to treat breast cancer. I'm going to let you kind of take over. This was done in our molecular tumor board, and we're just trying to share this with patients so they can see what the power of precision integrative medicine can do, because really a lot of people don't know. So I'm going to let you go ahead and jump in, John, and I'm going to come in and ask questions and interject as well.
That's
so
excellent.
Go ahead,
yeah, Dino, I want to begin by just sharing too that this is what's called an invasive ductal carcinoma, but of a triple negative breast cancer. This is what this ER negative, PR negative, HER2 negative means. Just to give everybody a context of this, triple negative breast cancers are a lot more difficult to treat, and they're a lot more aggressive than other forms of breast cancer. So this is a more advanced breast cancer. It also leads to difficulty for clearing out the actual tumor, and it leads to progression of disease if not treated correctly. And so as a result of this is, all breast cancers are not treated equally, but this is what we're leading into as far as the triple negative breast cancer.
So before you get started, John, what I want to point out too is that this type of cancer is more difficult to treat than those that are hormone positive, right? And I want to also point out that oftentimes these will return. They become difficult to treat. They can definitely decrease the quality and length of life of a patient. And the standard of care in treatment, most of the time when we see patients, and it's fair to say they've already failed the conventional, all the major institutions. So here we are now having to use precision and much better targeting to help the patient, because precision oncology is very rarely used. Less than 20% of all patients even get any kind of testing, let alone the level of precision at Envita, which includes immunotherapy precisioning, genomic precisioning, and on with adjuvant care. So with that being said,
immune targeting, looking at root causative aspects as far as what actually was the leader of actually root causes, maybe looking at, is there actually spread into the bloodstream, looking at cancer cell-free DNA, your circulating tumor cells, and what's the risk of there actually being further metastases. So all of this becomes a picture of lack of precision targeting. I'll give this example too, Dino. So, cancer back before, breast cancer is a good example of this because, 50, 60 years ago, it was just cancer. And then, oncologists started saying, well, what if we treated each cancer a little differently? Because it's not just cancer, it's breast cancer is a little different than the way that it acts with lung cancer or the way that it responds with colon cancer. And so it started to be able to actually look at it under a pathology and say, okay, this is breast cancer, so let's treat all of our breast cancers the same. Let's treat all of our colon cancers the same. Then we started looking in oncology at a couple of this basic level of staining under a pathology. And this is what we still use today. And we only are looking at ER positive, which means estrogen receptor positive, progesterone receptor positive, and HER2 receptor sites. And really then, so this is the extent of the conventional testing for breast cancers. Is everybody's familiar with, is it ER, PR, or HER2 positive or negative? And then if it's negative for all three, then it's like, oh boy, this is a really tough case because I don't have a target to be able to treat it. I can't just put you on a estrogen receptor blockade or a medication to treat that HER2 positivity. So it's like, well, I don't know how to treat it, so I'll just treat you kind of generically with these guidelines. that's what breast cancer patients are experiencing today, because of those three targets are the only precision that they're getting. But we're seeing that there's such a more vast opportunity for additional precision that breast cancer patients aren't able to actually receive, or they never even get offered.
Yeah, let me add one thing to this, which I think is critical for people and other physicians and groups that are listening to this little presentation. That the conventional model is outdated. It's archaic in many ways. We don't want to bring it down, but it's because it's so slow getting to people. Precision oncology is viewed as, you run it when you fail all the other standards. When we treat progesterone, estrogen positive, HER2 positive, the success rates are off the chart, even better. We're bringing this example of triple negative that's already failed standard of care because it's considered a difficult case. And we want to show you how precision makes a great impact on a difficult case. So John, let's jump in. And as we go along, I'm going to try to ask the questions that I think the patients love to ask. But listen, before we go on, it's by the grace of God we have this technology that we have here at Envita, where precision has transformed surgery. We do it differently, radiation differently, chemotherapy different, all with minimal invasiveness, extreme targetness, and patients having better outcomes, better quality of life, and total care. So as you go through, and we're going to start with this. This is a 60-year-old female with triple negative. So go ahead and jump in. This is from one of our recent tumor boards, and we're doing our best to try to share information.
Yeah, so we talked about the difficulty of already in the conventional system of having a triple negative breast cancer. This was a stage 3, which means that the cancer has already gotten out of that initial location, which is where it grew. It's already continued to advance. So if it's already metastatic, meaning that it's already transformed from the original tumor site, extending out into other distant sites. And so it was a stage 3, which that conventionally worsens prognosis when it extends out.
How many distant sites?
If
you want me to add, how many distant?
There was 2 to 3. So stage 3 wasn't completely all over the body. It was the size of the tumor, and then the couple of sites that was actually already in the lymph nodes. And we'll talk about that. I have an image as far as how that actually looks. But what we actually saw here, if you notice here on the slide, is that she consulted with oncologist and breast surgeon, but was unable to pursue their chemotherapy, their standard chemotherapy surgical plan, actually based upon their insurance and financial limitations. And so she wanted to be able to seek a different option that was actually precision, that was cost effective for her.
So let me add this. So the fact that the patient's insurance company wasn't going to really cover care, she decided, let me go get better care. Let me start doing some homework because I want the best if I'm going to, not get any coverage from insurance. So that makes sense to me now, because oftentimes what people don't understand about Envita is that we are 50% the cost of conventional oncology with 10 times technology. And so when the patient's out there looking and needing help, they're starting to see, okay, apples to apples, Envita is going to outperform in the precision area extremely. Right. So go ahead, continue. I just want to put that in there.
Upon the original, the consultation, we discussed being able to begin what we call GTF chemotherapy. This is genetically targeted fractionated chemotherapy that's done specifically for the genetic targets that are found on the actual cancer, and the precision chemo. And we also do it in a lower dose to be able to help the body support being able to have better targeting and better attraction to that actual cancer. So we can do it in what's called a metronomic form. And this is a lower dose, but more consistently, so that the body we can bring in the chemo to be able to actually kill the cancer, and then detoxify the chemo so that it's able to not build up in the patient's system and it destroys the system.
So in layman's terms, you're getting extreme targeting with many more factors at play. So we're looking at the treatment being designed with advanced algorithms from our years of work, genomically, immunotherapy, adjuvantly, all with microdose. The difference is oftentimes these patients don't have the side effects. Our 2020 data showed 89%, I believe, of our patients had less side effects than previous chemo because of this When you have the right targets, you don't need these massive doses that are just basically taking guess shots at the patient. We're not guessing here. We're so dialed in that micro or metronomic dosing is allowing us to get the maximum benefit with the minimal side effects, which is so important because that's what we want for our patients. We want to bring them healing without harming them. So that's the targeting. And that GTFC, which we've been doing for a long time, genetically targeted fractionated chemotherapy, is unique to Envita because of the algorithms we use in drug selection, using advanced genomics, using immunotherapy targeting, using other informatic data to help develop the protocol. And then we're giving it sometimes at 10 or 12 or 15%, the normal dose of chemo. You heard that, a fraction, because we know the targets are correct. So you're reducing side effects, improving targeting, and I'll just let you continue because in here
it's called adjuvants. We use appropriate adjuvants, which means in oncology, help and support drugs and medications and integrative therapeutics, nutrients, to help support, to allow the actual drugs to have a better effect, a more maximized effect. And that's where being able to use those adjuvants, we see that the cancer becomes more susceptible to the drug targets that we're actually targeting.
So this is where 1 + 1 = 5 instead of 1 + 1 = 2. Because if you have the right adjuvants with our data, we look at what blocked treatment before for the patient, and we try to overcome that by bringing in the right adjuvants to turn response rates back on for the patient, which is tremendously different. Now, in that same algorithm, I'm going to skip past PD-1 inhibitors. People may know they're very commonly used. They've been around. We've been using them on and off label for a lot of years to help natural killer cells. But I want to focus on this other very important treatment in here called CIPI.
Yeah,
so
absolutely.
Let's talk about that.
Yeah, what we say here is we use the direct CIPI injections to the breast and to the lymph node lesions. Again, we did multiple injections of this, and what it stands for is chemo immuno precision injection. And this is where we take these algorithms and we design the chemotherapeutic targets that are going to actually not just kill the cancer, but also they are very specialized to help aid the body's own immune system. So the chemo kills the cancer in which it's injected, but they also build the immune system to be able to really be able to target that area. We also use immunotherapies in this process to be able to directly inject to allow for the system to be able to actually garnish and say, hey, immune system, I'm over here. Because cancer is very good at evading the immune system. Something's gone wrong with the body. Everybody that has cancer, there's an immune system defect where the body has not been able to recognize that cancer effectively. So what we do is we start tagging that with a direct precision injection, sometimes with a catheter the size of your hair, to be able to go directly into where the cancer is at and to be able to start tagging it to allow the immune system to target that. Now, what's really beautiful about this injection as well is that it doesn't just hit the targets that you treat it with, but you also get a systemic response. When the immune system starts to be able to understand this cancer for what it is as a diseased tissue, then you start to be able to experience the immune system recognizing cancer cells elsewhere within the body. These could be main tumors or even micrometastatic disease, which means that these are single cells that have maybe gotten loose and started to be able to, in breast cancer, many times you see metastatic disease happen in the bones or in the liver, or sometimes even the brain. And it's a single cell and it's just waiting dormant there.
So let me add to this a little bit. So this is particularly important in triple negative and other breast cancers because there's a percentage of these that have a high propensity to return.
And
so immunotherapy, which I've been working on for 23 years,
even if it's a stage one, even at stage one, there's a propensity. Even if you've removed it with a lumpectomy or mastectomy, it still has a propensity to return and into distant sites.
So the critical piece here is that the immune system has a way that if you give, so what we're doing here with a catheter the size of a hair, we go right into minimally invasive, right? This is a local anesthetic, minimally invasive. The treatment is direct to the tumor under image guided. So this is all image guided under our interventional radiology oncology suites where we have very skilled interventional radiology oncologist, and it's image guided, genetically targeted, immunotherapy targeted, direct to the tumor. This is so powerful for some patients because not only do you get the tumor to die at the tumor site, but then you get this release of antigens or information so that the rest of the immune system can seek and destroy other cancer cells throughout the body. This is what helps tremendously in reducing the return of disease and having a better longer-term prognosis. Immunotherapy, time and time again, since I worked on building protocols over 2 decades ago, is the pinnacle and essence of cancer treatment because it can think, unlike chemotherapy. It moves. If it has the right targeting, it'll seek out other cancer cells, and your own body's ability to fight is critical. So this therapy is direct to the tumor with precision, image guided, so you get that nice death, necrosis at the tumor, but then you get a release of information so the rest of the body can turn on and recognize, okay, this other cancer or precancerous cell can seek and destroy with the immune system and not spread any further. That's the goal, the aim, and the work that we do with chemo immune precision injection, and do it throughout the body. This just happens to be breast cancer, but this is critical in the triple negative. And we've seen some very good results. So I'll let you continue, John, as you're going through this case.
As you can see here, again, you see all the different areas where the actual breast cancer is actually located here. You actually have quite a lot of of the tumor. So the tumor, this is a pretty large sized tumor. It was 4.5 by 3.8 centimeters. What does this mean? It's a little bit smaller than a Lyme, is a good understanding of how big that is. Right there at the actual breast, a little smaller than a Lyme. And that you also see that there are, again, roughly around, it's talking about 4 prominent left axillary lymph nodes. That's armpit lymph nodes in that same area. So you have, it's moved.
It's moving.
From the breast,
it's invading the lymphatic
it's getting
system.
into the lymphatics, into these actual lymph nodes. And these are about 1 centimeter. This is about the size of a blueberry. So you have all these 4 blueberries that were in that actual, in the armpit area. That the next step is that it moves into the blood, moves into the bone or the actual liver or the lung, usually with breast cancer. But this is what was originally seen. I'll give you a picture as we actually are able to see exactly where this actual these.
This is just as you continue. This is invasive ductal carcinoma. This is more difficult than your typical type of breast cancer. And we use this as an example because this is promising technology that makes a great difference in quality and length of life.
This is the type of imaging, and what I want to direct your attention to. So you'll see this on this imaging. We used a technology that's able to actually allow the cancer to take up contrast really effectively. So what you're actually seeing here is that all the black spots there in the upper right-hand corner of the screen, upper left-hand.
It's upper left. It's in the left region of the breast,
for the patient. But what you're seeing on your screen, that big circle, what you'll see is that the middle, the dark stuff in the middle and on the bottom, that's the kidneys filtering out the actual contrast. The bladder is collecting the contrast material. So that's why those.
Yeah, so all that matters here is the from your visual, it's the right-hand corner, correct. But the patient's left breast, you're seeing that metabolic uptake, which is, this metabolic uptake is classic in disease progression or sometimes
and you're seeing that large
activity.
Lesion. That's the 4.5 centimeter lesion. That's about the size of a Lyme. And then you see those there's a couple of dots that are represented just above that as well. Those are going to be the lymph nodes in the armpit. All right. I'm going to continue on so you can actually see then what was performed here. So like I said, we actually had the patient undergo our genetically targeted fractionated chemotherapy. This is IV and along with the chemotherapy, we're delivering it with our adjuvants that help and aid the targeting so we can do it in a fractionated dosage.
John, before you advance, I want to explain some things. In this particular protocol, ultrasound was used, but we oftentimes can use CT or we can use
That's right.
C-arm, right? Fluoroscopy. There's many different
That's right.
image-guided methods we get to get to the tumor. We
We do
have
what's
all
ever
kinds of
best for
imaging
the patient.
technology
We do
with
whatever
precision.
imaging is best for the patient to be able
That's
to
right.
treat and get to where the actual lesion or the mass is located. Yeah. And so what we see here, we actually delivered
Go
two
ahead.
chemo immuno precision injections directly to the tumor. And let me tell you this as well, you're not giving it to where it's going to harm the bone marrow or detoxing from the liver, because you're giving these medications directly to the site of where that actual tumor is located.
So you're sparing the body from toxic chemotherapy and getting it right to the region of
That's
where it's
right.
supposed to go. What a novel concept. It goes right to where you want it and not
So
damaging
what you can
other
see
healthy
here is
tissue
that
in the
we
body.
actually used those injections to be able to go right into where the breast, the main, that 4.5 centimeter lesion was. And we also did 3 of the lymph nodes. Okay. Then what we see here too is we used a technology called cryoablation. Okay, let me share about this. Cryo meaning freeze, ablation meaning kill. What this is that I think many people are used to going to the dermatologist or have heard people going to a dermatologist and having a area that's a concern, and the dermatologist takes something that freezes it at a very cold temperature and freezes off that concerning area or that cancer that's located. We use the same technology, but not on the skin. We go directly to where the tumor is at and we freeze it. And this is what we also did. Now, what's beautiful about this case and why we use that technology is because when we inject these immune system markers that recognize and flag that cancer to say, hey, I'm over here, immune system, pay attention to me. And then we go in to kill it with the freezing it. It says it keeps the antigens, it keeps the markers, the information that the immune system needs to continue to keep killing the cancer, killing it in that area. So we don't want it to just be, we say, we don't want to just pet the cancer. We want the cancer gone and we want it to stay gone. And we want the immune system to recognize it so that it's always going to be there. So we're going to freeze it off. And then we're continually keeping that information that the immune system needs to be able to keep the immune system targeted so that it doesn't return.
So let me take a moment here, John, to explain this. I think this is really important. In the typical scenario, you would get systemic, simply IV chemotherapy. Then maybe if it shrinks, you would go in surgically, lumpectomy, mastectomy, but it has an opportunity to spread. Look at the technology
And
difference. First
then
of
you
all,
would
all
probably
the
come in
agents
with
going into the,
radiation.
hold on, go ahead.
And then the radiation is usually
That's right,
external
to get the
beam,
margins.
and there's a lot of burns, and that there's a lot of the radiation goes through usually where the lungs are at in the heart, and you have long-term risks
It's
of fibrosis of the lungs, and you have long-term risk of cardiotoxicity in.
It's archaic. It's archaic. That's why when we say Envita's care is many years ahead of the rest, that's archaic. The point I'm making is, though, what goes into that tumor has been targeted genetically, immunotherapy wise before, and the medicines are custom made for the patient in our facilities, then delivered directly to the tumor. Now, you might say, why did you inject the tumor first before you froze the tumor? Because in essence, we wanted to squeeze the tumor almost like an orange, as the analogy, like squeezing a lemon or an orange, to get the antigens and the immune system and the rest of the body. It doesn't spread the tumor. It actually is just the antigen. So it gets the immune system to recognize and get rid of all the microdormant metastases that you can't even pick up in imaging that are already laying ground in stage 3. Oftentimes, these patients are farther advanced than you can see in imaging because it's happening at a cellular level, which you can't even pick up with imaging. Then, instead of surgery, we go in again with a minimally invasive procedure where you're out the next day, no major discomfort, and you freeze the tumor because it replaces surgery. So there's no need for reconstruction, no need for all that surgery. And then what we've done is we've created an immunotherapy response, plus we've killed the tumor because of the freezing at that region. And now you have really advanced in all breast cancer types, I'm going to say all breast cancer types, you've advanced and changed the game for the patient to live longer, better quality of life, using newer technology. There's none of this external beam radiation burning them. There's no surgery that can potentially spread, cause further spread in later stage disease. This is more precise, more elegant. So I'm going to have you continue. This is very important because, oftentimes, patients don't understand the differences. They'll think, oh, it's all the same. No, it's incredibly different. And it's more
All
precision
right.
to the care.
Here's the image that was performed just shortly following, and as you can see, the armpit, that main Lyme-sized area,
How long was this,
was
John?
only a couple of
How long was this
this was
before
only a
the
couple
second
of
image is
months
taken?
after from the beginning of care.
So
Six,
like
I
6
do
to 8
believe it was
weeks, 6 to
8 weeks.
8
I
weeks or
believe it
so.
was 8 weeks.
8 weeks. I mean, that's fantastic. In 2 months, you have the entire disease cleaned up from the breast. You can see there's no more tumor up in the breast area by the arm. All the lymph nodes are cleaned up. And the patient has now got a new course on
That's
trajectory of care and life. It's
that's
very good. Very good work. Right. We have a very good team. We have a brilliant team of physicians that do an amazing work and utilizing the advanced technology that has been brought into play for these patients. So good
No,
work.
so I mean,
Continue. I'll let you
well,
keep going if
that was
there's
the
anything
extent of
else you
what I
want to
wanted to
share.
be able to share. I thought it illuminated some of the technology. This is just some of the technology that Envita has,
Yeah.
and it again for these aggressive cancer types, the triple negative breast cancers. This is similar technology, but we base it around the individual. So it's not just negative breast cancer; it's other
Well,
types
I
of
also think
cancer.
this is a good case. Yeah, this is a good case because we don't treat cancer like other top facilities across the country that base it on tumor type and stage. It's invasive ductal. We're going to use this guideline and no, everything at Envita is custom built. So we've used this technology with many different types of cancer types and have great success because the treatment is built on the patient's specific tumor and their particular differences of the cancer, and that makes a great difference. And when you understand we're able to provide what I call technology that's 7 to 10 years ahead by the grace of God of what you see elsewhere, and we're doing it at half the cost of conventional care. That's important because now we're seeing employer groups, after many years of hard work, joining us and saying, Envita, will you be our center of excellence for cancer? We want to get our patients in and out. This patient doesn't need mastectomy, breast reconstructive, downtime. These are quick procedures, in and out. That same night, they're home. They're out of pain. They're good. They're already feeling good. And now, is this every single patient we treat? No, but there is a lot of great stories like this in our facility that we see benefits from, and we just want to share this because oftentimes we're so busy at Envita. We don't get time to share our protocols and the way we approach care that's incredibly different. This is breast cancer, and I think if you look at the data that's been put out, there's data that suggests that cancer by 2030 will surpass heart disease as the number one killer. It doesn't have to be. With precision targeted care, the earlier you treat it, the better, the less worries, the less toxicity and side effects. You notice we were able to spare the chemo from the body and treat the patient at the site. And then we're using integrative natural agents. That's why we're integrative doctors to strengthen the patient. So not only are they doing that, but they feel stronger, and we're going after the cause. Maybe the cause of this cancer could be infectious or chemical or heavy metal or hormonal, and we're cleaning that out of the body, cleaning the liver, building the immune system. Whereas sometimes on those bell ringing ceremonies that we get at Envita where people are leaving, they feel better than when they first came in because they're repairing the cellular metabolic issues that led to the cancer in the first place. That's why integrative medicine is absolutely necessary in the treatment of cancer because it strengthens the patient. It goes deeper in care.
Medications, big
It
pharma
just
alone
does.
doesn't do that. It doesn't do that.
No.
Big pharma is pharmacology is a big part of genetic targeting, but it does not rebuild the patient like the integrative medicine rebuilds the patient.
No, and even with our genetic targeting, we even genetically target the integrative agent. So we go way beyond the standard of precision care. Well, listen, Dr. John Oertle, thank you for joining me as we did this quick presentation. Not so quick, but around 30 minutes. Hopefully this was useful and helpful to our patients. May God bless you on your journey to healing. If you need us, we're here to help in any way that we can, and we wish you all the best on your journey to health. Thank you for joining us.